Good evening. I'm very happy to contact you all and to give this lecture. Thank you, Mohammed, for the very nice introduction words. It was really very nice. I hope that the slides are okay now. Um, I was asked to talk to you to factors supporting immunity in infancy, and I think that the actual situation in which we are living now with COVID and immune defense illustrates the necessity of a good immune response very well. So the layout of my presentation is a short introduction, and then we will focus on a probiotic and its impact on the immune system, Bifidobacterium lactis. Talk a little bit about human milk oligosaccharides, and that can only be of value if there is also optimal nutrition, and so an optimized protein content is very important, and we'll come to conclusion. Before starting, it goes beyond everything, of course, as you see in the left part of the slide, that breast milk is by any way the best way to feed all infants, and no discussion about that. Infant formula will only be second choice infant feeding. Breast milk is absolutely the way to go. So as I said, cow's milk based infant formula is our second choice infant feeding. And why do we use cow's milk based infant formula? Simply for the fact that there are many cows which provide a lot of milk, not because the composition of cow's milk is very similar to the composition of mother's milk. Also, what is very important is to realize how nutrition during early life does have an impact on health outcome lifetime long. And the first 1,000 days are therefore of major importance because that's when your immune system is developing. And important to realize also is that we will focus today mainly on the part after birth, but in fact the first 1,000 days starts not at birth, it starts at conception. So the first third part of those 1,000 days is the 9 months of pregnancy, and then the first and the second year of life of that child. So the programming that takes place during this period has a lifelong impact on many aspects of future health, including physical growth, but also including metabolic programming, including development of the immune system of the young child. And all that is partly under the influence of genes. So you have three pillars. It's genetic background of the individual, the environment, which plays a role, and the gastrointestinal microbiome, which plays a major role in the programming of the future health outcome of that young baby, of that individual. So what happens during early life will have an influence, I hope, on the next 95 or 97 years. So there are a lot of environmental factors which play a role. And genes, they do not change, of course, but genes can be put on an on or an off mode, so they can be made active or relatively quiet. And that's due to epigenetic factors, which are under the influence of hormones, medications, toxins, but also certainly under influence of food. And therefore, appropriate nutrition during early life will have an influence on the on-off function of some of the genes. So stimuli influence gene expression through epigenetic processes that selectively switch genes on and off. And that's why nutrition during early life is so important. So how can we get as good as possible second choice infant feeding? Again, remembering that breastfeeding is, of course, the first choice infant feeding. And what's the role of probiotics, such as Bifidobacterium lactis, on that? B. lactis or B. bifidum or BB12 or Bifidobacterium infantis, they are in fact all the same, and they are among the probiotics which are most frequently used and which were historically also about the first ones to be used, because historically the first study putting attention to the role of probiotics, Streptococcus thermophilus, in addition with Bifidobacterium bifidum, was for study from Pepe Saavedra already 25 years ago published in the Lancet. And it was in fact a study in a relatively small number of children which were hospitalized for a long time because it were neurologically handicapped children. And what he could show is that you get a significant reduction of nosocomial diarrhea by adding those two probiotic strains to the nasogastric tube feeding that those children were getting. So this was the first study bringing attention to the fact that if you add probiotics, you may decrease the incidence of diarrhea. B. lactis specifically has been added to infant formula, and when you add substances to infant formula, you always need, first of all, safety studies, nutritional studies, and that is illustrated in this study from France, which show you that a formula with B. lactis and prebiotics, that the growth of those children was completely normal compared to other formula-fed infants or compared to breastfed infants. So Hania Sajewska did also a meta-analysis on the growth of children with formula supplemented with one side Lactobacillus GG, but also with B. lactis. And the conclusion of that meta-analysis was that supplementation of infant formula with B. lactis results in growth similar to what is found in infants fed unsupplemented formula, and so normal growth. And then several studies have been performed by adding B. lactis in infant formula and evaluating the incidence of acute diarrhea. And what this study shows you is that you get 3 out of 4 studies where B. lactis is shown to be very active in the prevention of acute gastroenteritis. So you get a better response to potential pathogens. Children are better protected to those infectious agents. If you give infant formula with B. lactis, there is a prevention of acute gastroenteritis. The ESPGHAN did a meta-analysis of all the published literature with B. lactis on the risk of gastrointestinal infections, and in fact they concluded that B. lactis added to infant formula reduced by 50%, 46% to be exact, the risk to develop diarrhea. So addition of this probiotic to infant formula decreases significantly the incidence of gastrointestinal infections. The amount added can be also very relevant. A study from Asia showing that the more probiotics, the better the protection that you get less rotavirus shedding with those with the high concentrations. And that's all because of a better immune response. So this is a study looking at the effect of bifidobacterium to the antibody response after vaccination for rotavirus and polio. So the upper part of this slide shows you that especially in children born after C-section, which are those children with the highest risk to develop immune-mediated diseases, who have a development of an abnormal gastrointestinal microbiome, that the control group compared to the probiotic group, you had much higher antibody response to vaccination, especially in the children with C-section. The same is true for the anti-polio vaccination. Again, you'll see that in the children with C-section, you have a significantly better response to the vaccination. And that's related to higher levels of secretory IgA in the stool. So you get a better immune response to vaccination if you give infant formula with this probiotic. B-lactis has also been studied in preterms, which are of course at risk for developing necrotizing enterocolitis, and it shows you here that B-lactis is also effective significantly in reducing necrotizing enterocolitis and or associated death. So B-lactis certainly improves the immune response and protects for infectious diseases. What about human milk oligosaccharides and their effect on the immune system? I'm sure you have all heard that human milk is rich in oligosaccharides. It's in fact the third most important component in mother's milk after lactose and fat. And one of the huge differences between mother's milk and cow's milk is that the third most important component in mother's milk is virtually absent in cow's milk and virtually absent in infant formula as a consequence. And these oligosaccharides are very important because they have a prebiotic effect and they stimulate the development of a healthy microbiome. So they have prebiotic properties, which means that they stimulate selectively healthy microorganisms, which confer a health benefit to the host. And they are unique for human milk. There is no animal milk which is rich in oligosaccharides. They are partially digested and act as prebiotic by stimulating the development of that bifidogenic microbiome. And mother's milk is very complicated and complex, and so it's not one or two, but it's in fact more than 150 up to 200 different ones, different oligosaccharides, which have been discovered in mother's milk, and the composition changes all the time during lactation, during breastfeeding. It's different after 1 week than after 1 month. Okay, so it seems I speak too fast. I'll try to speak slower. What do we know about HMOs? Well, as I said, they are unique in mother's milk, and it's not a new discovery, because already from 1900, we know that there is a difference in the stool composition of breastfed and formula-fed infants. And we know since 1930, so almost 90 years ago, almost 100 years ago, that bifidogenic factor in human milk are in fact those oligosaccharides. And from 70 years ago, we discovered and characterized a lot of those oligosaccharides in human milk. So in fact, there is nothing new. The only aspect which is new, that due to technical possibilities, technical innovation, that today 1, 2, or 3 of those human milk oligosaccharides can be made artificially, chemically, in a factory. So it's not coming from human milk at all, but it's exactly the same molecule. So today we can add something into our cow's milk infant formula, which is chemically made, but which is identical to what is present in mother's milk. And is it important to have that prebiotic effect? Well, this slide shows you the microbiome in the breastfed infant. And it shows you that it is mainly predominant with bifidobacteria and very few coli and bacteroides. If you give non-supplemented infant formula, so basic cow's milk infant formula without pre or probiotics, then you see that bifidobacteria are still the predominant, but much lower level than in the breastfed baby, and much more coli and bacteroides. So the first colonization during the first weeks of life in a formula-fed infant, which is not supplemented with pre or probiotics, is totally different from the first colonization from the breastfed infant. And that might explain why there is that difference in health outcome between breastfed and formula-fed infants. The difference in microbiome may play a role lifetime long, because that microbiome is very important for a lot of functions. It has protective functions against pathogenic bacteria. It also stimulates the immune development. It stimulates the development of IgA. It controls local and general inflammation, tightening of the gastrointestinal junctions, and it induces tolerance to food and food antigens. So the role in immune development of a healthy microbiome is of major importance. That microbiome has also a role in digestive and metabolic functions, and last but not least, also in neuronal development, because a healthy microbiome will modulate the gut-brain axis during neuronal development. It also has an influence on motor control and anxiety behavior. So your microbiome in your gut has an influence on behavior and behavioral diseases. So in human milk, that is organized by the presence of those human milk oligosaccharides. And there are three large different groups. It's non-fucosylated HMOs, fucosylated HMOs, and sialylated HMOs. And today it's 2FL, which is one of the fucosylated HMOs, and LNNT, which is one of the non-fucosylated HMOs, which can be added to infant formula. So, and these so-called neutral HMOs, they account for over 75% of all the HMOs. Now, just as content of mother's milk in protein and other nutrients, the content of HMOs changes also over time. So the amount and composition of HMOs vary between women and over the course of lactation. It's nicely illustrated here for 2FL and LNNT, where you see how from the first 2 months, 2 to 4 months, 4 to 8 months, it decreases over time. And the same is true for LNNT. And you also see that the huge difference between presence of 2FL and LNNT, where 2FL it's 2 grams per kilogram and LNNT is only 100 milligram. So the total HMO concentration is higher at early stages of lactation and decreases over time. And preterm mother's milk does contain lower amounts of HMOs than term milk. So those neutral HMOs predominate in the first 2 to 4 weeks of lactation. Another important factor that we learned is that the amount of 2FL and the amount of HMOs is not the same in every mother. And that's partly also genetically determined. because it's genes which will determine if the mother is secretor or not. So a combination of Lewis gene, which is one of the blood group genes, together with secretor genes, which will in part determine how much and which HMOs are present in mother's milk. So Lewis gene positive and secretor gene positive, they contain all HMOs. Lewis gene negative and secretor gene, they still secrete 2FL and other HMOs. Secretor gene negative, there is no 2FL anymore. So that's a huge difference in which oligosaccharides are present in mother's milk. It's partly genetically determined. Why it is like that, we still do not know. That's a reason for further research. But what we know now is the main mechanism of HMOs. It's 4 different main mechanisms. The first one is to stimulate beneficial bacteria development in the gut. So some strains of bifidobacteria will use only HMOs as the sole source of carbon. So HMOs promote a protective commensal gut microbiota by selectively promoting the growth and metabolic activity of bacterial bifidobacteria. So that's certainly a difference with GOS and FOS or other prebiotic oligosaccharides because some of those bifidobacteria strains will only grow in the presence of HMOs and not in the presence of non-human oligosaccharides. Oops, sorry. Does that amount of prebiotic oligosaccharides, the amount of 2FL, play a role in the daily clinic? So this is a study in exclusively breastfed infants, secretor and non-secretor mothers. And so you see clearly that the amount of bifidobacteria in the stools of infants of a secretor mother is much higher than the amount of bifidobacteria in infants of non-secretors mothers. So that does have a different effect, being secretor or non-secretor. HMOs also strengthen the barrier function. That effect is structure specific and has not been seen with other oligosaccharides such as FOS and GOS. So HMOs have been shown to improve the host defense by strengthening the gut barrier functions. And they will directly interact with intestinal epithelial cells and modulate their expression. And as a consequence of that, HMOs do have an effect on presence or absence of pathogens. What has clearly been shown is that 2FL protects against infectious diarrhea. 2FL protects for Campylobacter diarrhea. In another study, has been shown that 2FL inhibits the adhesion of Campylobacter to the intestinal cells. And finally, another study in HIV-exposed children, the addition of 2FL was associated with a reduced mortality. So this is a study in exclusively breastfed infants. So it's no formula feeding at all, looking at the incidence of diarrhea. And what it shows you that if the infant exclusively breastfed gets a low amount of 2FL, a low amount of human milk oligosaccharides, or a medium amount or a high amount, the protection against Campylobacter diarrhea or against all causes of diarrhea is totally different. So with low levels of 2FL in mother's milk, the risk for the child to develop all causes of diarrhea or Campylobacter diarrhea is much higher than if it's a child from a secretor mother who gets much higher amount of 2FL. So HMOs are clinically relevant to protect against diarrhea with high levels of 2FL, which are associated with greater protection in exclusively breastfed infants. Other illustrations of the benefits of those oligosaccharides is that human milk oligosaccharides have also been shown to inhibit the growth of group-based streptococcus. And you know that that is an important pathogen for the newborn. So in the presence of HMOs, group-based streptococcus grows much more difficult than in the absence. And so HMOs will also induce the development of a balanced immune system. So a little bit of basic literature showing you that HMOs can bind to cell surface receptors expressed on epithelial cells and cells of the immune system, and thus modulate neonatal immunity in the infant gut. Or because human milk has pre and probiotic properties, the anti-allergy protection afforded by human milk may be due to its control on the development of the developing gut microbiome. So because of the prebiotic effect, you stimulate your development of your microbiome into the right direction and stimulate the development of your immune system into the direction of tolerance. And so investigations are, of course, needed more to better investigate the specific role of HMOs in prevention of food allergy, but there are quite some in vitro data which suggest that HMOs do help to prevent allergic disease. We are maybe at this moment missing some data in infants, clinical data with infant formula. But again, if you look at exclusively breastfed infants, there are data that HMO do protect for the development of atopic eczema. Just as I showed you for the exclusively breastfed infants and the risk to develop diarrhea, is just the same here. So the exclusively breastfed infants with low levels of 2FL or with high levels of 2FL, the difference in risk to develop atopic eczema is 3 times, 14% or 43%. So again, within exclusively breastfed infants, the amount of HMO predisposes the risk of the child to become to develop atopic dermatitis or not. And this was again just like for the vaccination study with Bifidobacterium lactis shown in infants born after C-section, which we know have a much higher incidence of allergic disease than vaginally born children. There are also still other clinical outcomes which are very interesting and relevant for the HMOs, and it's their effect on the brain and the enteric nerve system. And that's because 2FL and other HMOs contain sialic acid, which is not present in FOS and GOS. And that sialic acid, a very small proportion of that, 1%, is absorbed and transported to the brain. And so HMOs provide sialic acid as potentially essential nutrients for brain development and cognition. And that might be one of the reasons why infants which are breastfed have a slightly higher IQ than infants which are formula fed because of that presence of sialic acids. So several studies have been performed showing that 2FL affects cognitive performance and improves learning. 2FL significantly improves the long-term induction and maintenance of the hippocampus, so an anatomic effect, and specific HMOs support behavioral responses during stress exposure. So clear effect of HMOs on behavior. There are, of course, already some clinical studies performed with the addition of 2FL and LNNT to infant formula. And this is a study which was published 3 years ago, showing a reduced morbidity and reduced medication used in a group of infants receiving formula with 2FL and LNNT compared to a group of formula infants with unsupplemented formula. And what was shown is that you got a reduced incidence of infections and infestations, lower respiratory tract diseases, notably bronchitis, up to the age of 1 year. And what is relevant to remember is that the intervention was stopped at 6 months. So the study ended at 6 months, HMO versus no HMO, but at the age of 1 year, you still got a significant difference. And there was also a significant decrease of use of antibiotics and significant decrease of use of antipyretics. But antibiotics are, of course, very well known also to change the gastrointestinal microbiome. And 1 week of antibiotics may take 3-4 months before the microbiome becomes again as before. So you get a reduced incidence of infectious diseases, mainly respiratory tract infections, and a decreased use of medication, antibiotics, which only confirms the health benefit of adding HMOs to infant formula. And a very recent study was performed with the 2 HMOs, LNNT and 2FL added to an extensive hydrolysate in infants with cow's milk allergy. But we looked in that study also at the incidence of lower respiratory tract infections, upper respiratory tract infections, otitis media, and use of antibiotics. And you see that you have a very significant clinically relevant reduction of respiratory tract infections. It's 40% less lower respiratory tract infections, 15% less of upper respiratory tract infections, 100%, but it's 7 compared to 0 reduction of otitis, and a 25% reduction of prescription of antibiotics. So it's just, this study confirms absolutely the previous findings from 2 years before with the 2 same HMOs added to intact protein, where here it's added to an extensive hydrolysate, but so clearly showing a decrease of infectious diseases. So again, all that as second choice infant feeding after breast milk. Away from the immune system is appropriate nutrition and appropriate protein content, also very important to avoid another, I think, upcoming problem with infant feeding and the risk for developing obesity later in life. Because I showed you first the difference between human milk and cow's milk for the presence and absence of human milk oligosaccharides, but the difference is as large for the content in protein. It's illustrated on this slide, where you have 3 times more protein in cow's milk compared to mother's milk, and the casein-whey ratios are also completely different. In the introduction, I talked to you, I mentioned the metabolic programming, and that's of course related to the amount of proteins which are present in the feeding. You get as functions of the proteins in the human body are chemical messengers, enzymes, energy, of course, transport, immune response, because amino acids contribute to normal immune function. Therefore, appropriate protein content is also very important. It plays a role in the regulation of fluid and acid-base balance, but protein, of course, is are the building blocks for growth and will have a huge influence on physical growth. And again, breastfeeding is of course the best way to feed infants, because if we compare formula-fed infants to breastfed infants do have a reduced risk to develop type 2 diabetes. As I mentioned, they have a higher, better cognitive development. There is a decreased risk of overfeeding with breastfeeding, decreased risk of allergic diseases, less respiratory tract infections, less gastrointestinal infections, decreased morbidity and mortality to all those infectious diseases, but focusing also on the decreased risk of overweight and obesity in childhood and later in life. And it has been shown that every month of breastfeeding reduces the risk for the child to become obese by 4%. So the effect of high protein intake on metabolic outcomes at 6 months, it's related to the weight gain. Because if you give too much protein, you give too much plasma insulinogenic amino acid, mainly valine, leucine, isoleucine, and threonine, and that will induce an increased secretion of IGF-1, and as a consequence of that, an increased risk to develop obesity. And that's illustrated also in this slide, where in fact formula with a high protein content, which is the red line, or a low protein content, which is the blue line, differs in the weight gain of the infants. And what you see is that with high protein content, during the first 2 years of life, at the age of 20 years, you see a difference of BMI of 22 down to 20, a difference of 2 units of BMI, kilogram per square meter, depending on the amount of protein which was ingested during the first 2 years of life. So a high protein intake will result in an earlier adiposity rebound and will increase the risk to become overweight. So if we compare the black lines are the amounts of protein in mother's milk, which you see decreases over time with the percentile 95 and the 97 and the percentile 3 of the protein content in mother's milk. And that's the content of protein in infant formula, a lot of infant formula today in the US and Europe with high or low. But what is important, therefore, is because that's still the low protein content infant formulas is still at 97% percentage of breastfeeding. So next generation formulas with clinical studies that have been performed have a lower protein content, much closer to the protein content in mother's milk. And what has been shown with those low protein formulas is that compared to breastfed babies, which is the zero line, the WHO zero line, how breastfed babies grow, that with this low protein formula, the growth of those babies is completely identical to that of mother's milk. So that brings me to conclusion of my presentation, focusing on the first 1,000 days of life, starting at conception and pregnancy, where breastfeeding is the best, weaning should be appropriate, toddlers feeding we did not discuss, but if the infant cannot be breastfed, I try to show you how we can influence formula feeding to give a nutritional approach to that child, which is close to that of breastfeeding. So the addition of B-lactis is important because it will stimulate normal growth. It has been clearly shown to protect for infectious diseases in prevention and in treatment. But what is especially important is the preventive aspect and the efficacy in prevention of both gastrointestinal and respiratory tract infections, and the better immune response, as has been shown in the study with the vaccination. And our intestinal microbiome development is very important for that development of the healthy immune system. Because if that's in symbiosis, you will develop immune tolerance, intestinal homeostasis, and have a healthy metabolism. If there is dysbiosis, you are at increased risk for immune disease, intestinal disease, such as inflammatory bowel disease, irritable bowel syndrome, also necrotizing enterocolitis. And dysbiosis also predisposes to metabolic diseases such as diabetes and obesity. There are, of course, ways how to influence the development of that intestinal microbiome. And today we focused on feeding versus breast versus formula feeding and how we can improve the composition of that formula feeding to have a healthy microbiome. Duration of gestation plays also a major role. The way of delivery is of major importance because infants born after C-section are at increased risk to have a dysbiosis. The environment plays a role, and antibiotics medications plays a major role. And we all know, and I mentioned that during the presentation, that antibiotics, they kill not only the pathogen, but also the healthy microbiome in the gastrointestinal tract. But we should not forget that proton pump inhibitors have exactly the same negative effect on the gastrointestinal microbiome than antibiotics. So the first semester of life is very crucial because genetic factors and epigenetic factors will play a role, but they can switch off and on those genes by the epigenetic mechanisms, as we showed. And that's also under the influence of the microbiome. And nutrition will turn on and off those epigenetic factors, low protein, high protein, probiotics, prebiotics. That nutrition will also have influence on that microbiome. And so the infant's first months of life are crucial for the development of the gastrointestinal microbiome and the development of that healthy, well-balanced immune system. And if that during the first months of life happens in a well-balanced way, the individual will take that benefit for the rest of his life. So early intervention and early prevention is much better and will have a much larger impact later in life than late intervention, because then the harm has been done. We can only change the immune system when it has to develop, and that's during the first weeks, first months of life. And with this last slide, I would like to thank you for your attention. I will try to do my best to answer your questions. Regarding HMO and prebiotic, it must be combined in same formula. I think there is nothing against in combining HMOs and other prebiotics such as FOS or GOS. I think that the future will, of course, be that HMOs will win it over the non-human oligosaccharides. So I always compare it to the development of the evolution of the iPhone. The first iPhone was very revolutionary. FOS and GOS was really important because it launched or started all the interest on development of a bifidogenic microbiome. But HMOs are better and are an advantage. So the iPhone 10 is absolutely better than the iPhone 5. So it's the evolution of science we always discover more, and so in the future more and more HMOs will be added to infant formula. It's clear that probiotics do reduce necrotizing enterocolitis in preterm babies, but what about extremely low birth incidence? It's safe to use in these babies. Yeah, we just with the working group, a special interest group of microbiota published in GPGN review meta-analysis of the probiotics to reduce NEC, and we made active recommendations for which to use and which cannot be recommended. I think also on the other side that there is also emerging literature on the use of oligosaccharides, human milk oligosaccharides, on the prevention of NEC. And I personally am convinced that in 5 years' time, we will use HMOs to prevent NEC, because then you don't have the safety issues. We know that the probiotics are safe, but it's always discussed, it's always coming up. And it's also a problem of viability of the probiotics in the infant formula, while with HMOs, we do not have those issues. So I think today, probiotics, yes, you should look in the meta-analysis and see what is present in your country, what has been recommended and not. But for the future, I think it will be HMOs. Published. I don't see if there are. Do you recommend giving HMOs to a baby with a formula that includes HMOs in it? If it's a formula with HMOs, it contains HMOs. Focused on protein and HMOs. How about other nutrients and micronutrients such as nucleotides, iron, zinc, vitamin D? Yes, it all plays an important role. Zinc certainly plays an important role. Vitamin D stimulates the development of the immune system. Could also talk about omega-3 fatty acids. It's of course complex, but we focused indeed on protein and the gastrointestinal microbiome, but it's certainly true that other nutrients do also have a role in the development of the immune system. Is there a role of HMOs in prevention of early malignancy? That has not been shown that it prevents cancer. Really, some babies have obesity during early infancy while they are only on breast milk. Yes, so almost exclusively breastfed infants are very rarely obese, but it's also genetic programming. What we know is that mothers or infants which are exclusively breastfed, that if the mother is obese, even if she exclusively breastfeeds, the risk of that child to become obese is much larger than if the mother was not obese. So that's the genetic programming, the epigenetic programming from generation to generation. Do probiotics influence the function of T regulatory cells in the gut? Yes, probably they do. That has been shown for some of the probiotics in vitro studies. What are the main groups of protective microbiota in newborn and later in life? Well, it's mainly bifidobacteria and lactobacilli. And then there is also strain specificity. The role of prebiotics in NEC and extreme premature. Yeah, so that's what I explained, that HMO is probably going to play a role in prevention. Microbiota transplant using a single super donor produced high rates of clinical response in patients with irritable bowel syndrome in a trial published quite recently in Gut. I know my question is a bit far from the topic, but just presented very elegantly. Just wanted to know so it's about fecal transplantation. I think what we still are, I don't know this recent study in gut, I will look it up, but overall, I think that fecal transplantation up to now provides disappointing results for all those immune-mediated diseases. Fecal transplantation is very effective in the management of persistent or recurrent Clostridium difficile disease, but that's of course an acquired disease, which is the consequence of overuse of antibiotics. So what you then do with your fecal transplantation is you go back to the original microbiome. What you see what happens in, for instance, inflammatory bowel disease is that you can gain some time. If you do a fecal transplantation in a patient with Crohn, colitis ulcerosa, it will maybe go better for a week or a couple of weeks or 2 months. But at the end, the abnormal microbiome, which is certainly there in all those diseases, returns back. It comes back because probably it's that first colonization or what happens during the first months of life, which is very important. And once you have that microbiome, I think we can not change it. So I think that overall, fecal transplantation, except for acquired diseases in Clostridium, provides disappointing results. Medicines like domperidone will affect the quantity or quality of HMOs. No. Domperidone can be given for to stimulate the lactation, but the amount of HMOs is genetically determined, and so medication will not change that. So then I think would like to thank you for listening. Thank you for all the questions. I found some of the questions really stimulating and interesting, and I would like to wish you a further very good evening. Thank you so much.